All right, thanks, Dr. Believe. Thank you, everyone, for coming this morning. So, I think as everybody knows, the robot is a fairly hotly debated topic. In prostate cancer, there was a recent trial that came out, and there's no major differences in robotic cystectomy. There are now 4 randomized controlled trials, all quite small, and we're going to go over those today as well as other data that we've got so far. From our perspective as residents, I wanted to choose this topic because our rotations at VGH are changing significantly as a result of the robot coming into practice with the government now funding robotic prostatectomies and cystectomies. It's changing how we do surgery here at VGH and may change at other centers if there are more robots that come into the Lower Mainland. The big question with the robot, I think both in prostatectomy and cystectomy, is where is the data that is fueling the increase in utilization? And so we'll try and take a look at that today. One of the main things, there are significant assumptions by people in the public that the robot's new, you get great visualization with it, and so the robot must be better. And those assumptions in many ways are not true, and hopefully our data today will address some of those concerns. So our objectives today, we're going to take a look at the history of radical cystectomy. We're going to analyze recent randomized controlled trials, looking at open versus robotic approaches. We'll summarize and evaluate the available data, both looking at retrospective and prospective data, and then we'll discuss some of the future directions for robot-assisted radical cystectomy. So first off, just some background. Now, bladder cancer is the 4th and 12th most common non-cutaneous solid malignancy in men and women respectively. Approximately 2/3 of patients present with non-muscle invasive disease, and of these, around 2/3 will in fact recur. This causes a significant cost as well as time for urologists and for the healthcare system. What we're focusing more on is the muscle invasive disease, and about 1/3 of patients present primarily with muscle invasive disease. Now, going back to a study all the way from 1956 when they would just watch patients with bladder cancer, 2-year mortality from the disease was around 85%. So we know that we're not dealing with something that is indolent. Gold standard of treatment is neoadjuvant chemotherapy with radical cystectomy. Now, despite that being the gold standard of treatment, nearly 50% of patients with muscle invasive disease don't undergo curative therapy. Now, for people who do have curative therapy, approximately 45% of the total have cystectomy, and just under 8% undergo curative radiation therapy. So, in general, who should be offered radical cystectomy? Well, patients with muscle invasive disease, T2 to T4A, with or without nodes and with no metastases, and patients who are deemed surgical candidates. One concern with bladder cancer is that it does occur in older populations, and so often patients aren't surgical candidates, though here we do see a number of patients in their late 80s and early 90s who are receiving radical cystectomy. It also raises the question, with patients being so old, having significant comorbidities, any benefit in perioperative outcomes would be beneficial in this population, and that's what was hoped would be the case for robotic cystectomy. Now, also from the CUA guidelines from 2015, radical cystectomy is encouraged or recommended for patients with T1 high-grade disease with variant features, lymphovascular invasion, CIS or large size, early high-grade recurrence at 3 months, persistent high-grade T1 disease on restaging TUR, tumors involving diverticula, as well as high-risk disease unresponsive to BCG. Cystectomy's come a long way, both in open and robotics, and dating back to 1888, the first reported cystectomy was performed for bladder cancer by Bardenauer. Unfortunately, the paper was in German, so I couldn't get any of the details or look at mortality and morbidity rates for that. But then by 1939, Hinman reported periop mortality around 35%. In 1956, we had the first good description of a radical cystectomy. This was done by Whitmore and Marshall, and their periop mortality was down to 17%. 4-year survival, though, was only 18%, and over half of patients were actually receiving a full pelvic exenteration rather than just radical cystectomy. Now, this was, for me, a fascinating paper looking at some of the history, and so I'm just going to walk you through what they did. Patients underwent a 4-day bowel prep. At this time, they were weighed naked with their bladder empty prior to surgery so that they could have correct calculations or accurate calculations for blood loss and fluid resuscitation. They were induced with IV pentothal. They had 3 IVs placed, 2 15 gauge and 1 18 gauge, with the 2 15 gauges for blood transfusion. The patient actually started in the dorsal lithotomy position. They made a perineal U-shaped incision, and through this they dissected the prostate off of the rectum, and if they were unable to do this, then they would proceed with pelvic exenteration. They also encircled the urethra at the apex of the prostate for identification purposes, and entered the space of Retzius as well. The incision was a transverse incision between the anterior superior iliac spines, and at the time of incision they started blood transfusion. Mean blood loss was 3 liters. Their range was 1.7 liters all the way up to 8 liters of blood loss, and their average stay was around 1 month in hospital if there were no complications, but as you can imagine, most patients underwent or had significant complications. And the urinary diversion was done with cutaneous ureterostomy, so your ureters brought directly to skin surface at that time. So when you look back to 1956 compared to more recent data, this came out of MSK, their 30-day mortality was around 1.5%, which is similar, maybe slightly lower than other published data, usually around 2 to 3% mortality perioperatively. Complication rates overall were 64%. This was a study from looking at patients from 1995 to 2005, and we'll notice from the other trials we look at today that these complication rates have not changed significantly in the past 10 or so years. Main complications were related to gastrointestinal issues, infections, and wound-related issues. High-grade infections, Clavian 3 to 5, were approximately 13%. So, the question is, with the robot, are we moving forward or are we actually going backwards? The first laparoscopic radical cystectomy was performed in 1995, just a few years after laparoscopic surgery began its use in urology. The first robot-assisted radical cystectomy was reported in 2003 by Meenan et al. And in the US from 2005 to 2010, this is based on a nationwide inpatient sample looking at 42,000 patients, use of the robot increased from 0.8 to just over 10%. Now, since then, from SEER database, by 2012, there were around 18.5% of radical cystectomies being performed using the robot. So, whether there's evidence or not, the rates are definitely increasing, though not as significantly as in prostate cancer. Early reports were quite promising, showing significant improvements with the robotic approach. Wang out of Cornell published in 2008 a study looking at 54 patients with 21 done open and 33 robotically. They showed decreased blood loss, decreased transfusions, time to diet, and length of stay, 5 versus 8 days. Increased OR time was the only real downside that they found, and there was no difference in lymph nodes retrieved or in complications. What was interesting from this study is that extravesical disease was found in open patients much more significantly than in the robotic patients, suggesting a significant selection bias towards lower stage disease with the robotic cystectomy. A follow-up study published 2 years later from the same group at Cornell now showed decreased 30-day overall and major complications, with 8 versus 31% in major complications being quite significant. Lower blood loss, around 700 cc's difference. Shorter hospital stay, again 5.5 versus 8 days. No difference in lymph node yield or positive surgical margins. And we'll see in the future studies, lymph node yield and positive surgical margins were the way that authors reported quality of the surgery from an oncologic perspective. There were a few other early studies that also reported similar results, and as could be imagined from seeing this, many people thought that the robot was going to change how we do radical cystectomy. So then we come into 4 randomized controlled trials published between 2010 and 2016. All were small. 3 of the 4 were underpowered. All used extracorporeal urinary diversion, meaning the diversion was done using an incision and as an open technique. So the first study was published out of North Carolina by Nix in 2010, published in European Urology. They looked at 41 patients, 21 in the robotic arm, 20 in the open arm. This is a non-inferiority study done at a single center. Inclusion criteria is that you needed clinically localized cancer, and exclusion criteria, very basic exclusion criteria: not a candidate for either approach, not allowing randomization, and coming in with a preconceived preference for what they wanted. Now, in many of the studies, this preconceived idea that robotic surgery is better caused a number of patients not to participate in these clinical trials because they didn't want to have the risk, they would presume, of undergoing open surgery. Their primary outcome for this study was lymph node yield, and from previous retrospective studies, they determined that a 4-node difference would be considered clinically significant. Their secondary outcomes, similar to many of the other studies, were operative time, blood loss, return of bowel function, time to discharge, analgesia requirements, and positive margin status. In terms of neoadjuvant chemotherapy, none was performed. Adjuvant chemo in 6 of the robotic patients, 8 of the open patients. There were no conversions to open from the robotic group, and neobladder was utilized in around 30% of patients. Everybody was put on an aggressive feeding and mobilization protocol afterwards, and there were no differences between the 2 groups in terms of their set plan. So, primary outcome, lymph node yield, no difference. And you can also see, and this goes back to the selection bias, is that there were, even though it's not statistically significant in this case, significantly more patients with localized disease in the robotic arm as compared to the open arm.
They said it was randomized.
It is.
So there's no selection.
Sorry. Okay.
There is a pre-selection. You get in the trial, but not between the 2.
Not between, no. Perioperative outcomes. So blood loss was around half in the robotic group. OR time was an extra 45 minutes or so in the robotic group. Time to flatus and time to bowel movement was around 1 day less. And then their analgesia requirements were also significantly less. What they didn't find was statistical significance in length of stay or in complications. Now, limitations for this study, obviously it's underpowered. There were only 40 patients. It's a single center. It's the small number, no long-term follow-up. And I think in surgery for cancer, the main outcome in the long term is how patients do and survival rather than all of these perioperative outcomes. But for initial randomized trials, all of these, the 4, looked at really perioperative outcomes rather than long-term survival outcomes.
Can I just make a comment about clinical trial design? mean, for a randomized trial to be significant, the primary endpoint has to have some validated criteria and or efficacy of treatment effect. And yet this primary endpoint doesn't mean anything. You know, this number of differences in number of nodes hasn't been correlated to better outcome except through retrospective data. And if you're going to go to the effort of doing a prospective randomized trial, the first thing is to make sure your primary endpoint is appropriate, not just what statistical convenience to allow you to justify a smaller sample size.
Did they say why they chose that endpoint?
They said based on retrospective data, so they were trying to prove non-inferiority from a surgical or oncologic perspective, so they were hoping that by saying there's no difference in lymph node that the extent of dissection or the quality of dissection is equivalent or non-inferior.
And did they do a power calculation to see how many patients they should have had in each room?
Yeah, and it was much higher.
Much better.
But at the time, it was the marked prospective was or cystectomy was new, and everybody said you can't do it because you won't be able to do proper node dissection.
No dissection.
And that's the context. The main limitation people thought was going to be doing a proper node dissection. So I agree, it's not a valuable trial, but essentially they're trying to prove that you could do that with node dissection. But of course, everybody that takes a trial and looks at all the other endpoints and tries to say, you know, it's better in some.
What else they can find. Any other questions at this point? So moving on to the second trial, again, small, 39 patients. This was done by Perioperative et al. Out of the University of Texas, and this was a pilot study for what we will talk about later, another study that will be published called the RAZOR trial. Again, single center, pilot study. Inclusion criteria was similar, so T1 to T3 disease. For this, they did not allow patients with known nodal disease, and again, they had to be candidates for open or robotic surgery. Exclusion criteria similar to before, multiple abdominal surgeries, morbid obesity, or stage 4 bulky nodes. Their primary outcomes, they actually had 3 primary outcomes. The first was to just establish the feasibility of randomizing patients. So again, this was early in robotic cystectomy, and trying to just prove that a randomized clinical trial could be performed for cystectomy. Their other primary outcomes, looking at oncologic efficacy, so again, margin status and total lymph node count, and then perioperative outcomes similar to what we saw in the previous study. Secondary outcomes were complications. Again, in this study, no conversions to open were required.
They're all converted.
Yes,
Open
so
conversion.
no conversions to open for what was planned as an intracorporeal, or what was planned as robotic. They were all extracorporeal diversions, so all the diversions were done open. So, outcomes here, things that they found statistically significant, median estimated blood loss, so again, around half, though their numbers are quite a bit higher than in the previous study. And they found a number of patients that went home early compared to the open arm. What they didn't find was any difference in operative time, and this is the only study that found no significant difference. And they didn't find a difference in the median length of stay. Though more patients went home early, there was no difference overall in the stay. So their pathologic outcomes, again looking at lymph nodes, and here, though it's not statistically significant, there was a trend towards an increase in lymph nodes in the open arm compared to the robotic, and this is the only study that we'll look at that found this. Their overall primary aim was met. They found that they could randomize patients, and we'll see later in the presentation that they have done this for a larger clinical trial. Limitations, again, small size, single center, significantly underpowered, and no long-term outcomes.
It's not underpowered for what they wanted to do.
True, but I guess to look at their perioperative outcomes.
This is how you want to do it. You want to do a pilot, make sure you can actually randomize patients, and then launch the big multi-center trial. And this is all dependent right to first author. This is grant-funded research independent of the company. There's a model of how to do it.
So, sorry, it's not underpowered for determining feasibility, but in terms of the perioperative outcomes that they're looking at, the numbers are too small. The third trial came out by Bachner in 2015. So this was a larger trial. This was was planned to be adequately powered, looking at 93 patients in each arm. The study was actually stopped due to futility, due to not meeting its primary outcome at a predetermined partway analysis. Their hypothesis, I think, was the issue in this study. They felt that they could show a difference, an absolute difference of 20% decrease in overall complications for robotic versus open. So they estimated the open complications to be 50%, whereas they thought that the robotic complications would be only 30%. And as a result, the study ended up being underpowered and was stopped early. Again, up to T3 disease, you could have positive nodes in this trial and no metastases. Primary outcome was overall 90-day complications, and secondary outcomes were similar to previous. They also looked at total inpatient costs in this study, which we'll look at in a second. So the only things that they found that were statistically significant were OR time and estimated blood loss, and this is a recurring theme. So robotic surgery decreased blood loss, robotic surgery increased OR time. What they didn't find was any difference in complications, and their estimate of 50 versus 30% turned out to be 62 versus 66%. So the estimates were off, and we'll see that again in the next study as well. No difference in positive surgical margins, no difference in length of stay, and no difference in any of the complication rates. In terms of costs, what they found was for mono bladders performed robotically, there was a $4,000 difference, and for ileal conduits performed robotically, there was about $1,700 difference in costs, and this was just inpatient costs. There was a more recent study by Hugh and colleagues. It was a retrospective study out of Cornell, and they actually found no difference in hospital costs, but increased usage of home care nursing and increased costs at 30 days for robotic cystectomy versus open. So no huge differences in numbers, but what was originally presumed to be a decreased length of stay and the savings from that don't seem to be panning out based on this. Robotic still seems to be more expensive in the long run for hospital stay. And our final study by Khan, this was out of London. And this was set up a little bit different, 3 arms. So they did robotic, open, and laparoscopic surgery. Again, it was underpowered due to issues with their initial estimated complication rates. So they figured in open surgery 25 to 60% complications, whereas in robotic radical cystectomy, they were expecting complications in the 10 to 15% range, which again is significantly lower than any of the other data that we've seen. Similar inclusion and exclusion criteria, primary outcome being 30 and 90-day complication rates, and secondary outcomes similar to the previous studies. They also looked at 12-month oncologic outcomes as well. So a total of 59 patients, 20 or so in each arm. And what they found was that there was no difference in any complication or in major complications between open and robotic cystectomy. They did seem to find a trend towards improvements in laparoscopic robotic cystectomy, which I don't think they were expecting to find. In their secondary outcomes, there was a difference in operative time, an hour and a half longer for robotic approach. Time to oral solids was improved by 3.5 days, but again, in the UK, length of stay is much longer, and so things seem to go a lot slower. They have a number of trials with length of stay greater than 12 days. And again, I'm not going to go through all the numbers, but laparoscopic surgery seemed to show improvement over robotic, which, again, there's no great reason to explain that other than possibly the experience of the surgeon doing the procedures. At 12 months, no difference in recurrence, in overall mortality, or disease-specific mortality, but again, their numbers were very low, so I don't think we can take much from that. So, those are the 4 randomized trials. Now, there have been a number of meta-analyses that have been performed. The first one by Tang was published in 2014. Now, this was prior to at least 2 of the randomized controlled trials coming out. It only included 1 RCT from NICS in 2010, and then the rest of the data came from a mixture of prospective and retrospective data, primarily out of the US. Level of evidence was primarily 3B, except for the 1 randomized trial. And their findings, again, when you look at the retrospective data, there seems to be improvement. When you look at the prospective randomized data, there seems to be no improvement. So they found, similarly to all the other trials, OR time was 70 minutes longer for robotic cystectomy. Blood loss was 600 cc's less for robotic. Length of stay was 4.5 days shorter, but again, many of these trials had length of stay greater than 12 days, which does not carry over to our patterns here, where our robotic or open cystectomies are typically staying 6 to 8 days, unless there are complications. Lymph node yield was 2 more in the robotic group. Time to diet was 1.5 days less for robotic. And in terms of complications, they had an odds ratio of 0.5, confidence interval of 0.34 to 0.72. So they found statistical significance in decreased complications for robotic cystectomy. Most of the complications were related to infection, whether it be wound infections, urinary tract infections, or GI infections. The only increase in complication for robotic cystectomy was actually with ureteric obstruction or stricture. Again, significant selection bias towards lower stage disease in robotic cystectomy compared to open. So their conclusions from this were that in appropriately selected patients, there may be some better outcomes. So quite vague, and I don't think it really shows us much looking at the retrospective data. Then we have from TAN, published in 2016, we have a meta-analysis systematic review looking at just the 4 trials that we looked at previously. So just the 4 randomized controlled trials, a total of about 240 patients in the 4 different studies. All diversions were performed in an extracorporeal fashion, and there were a similar number of neobladder versus conduit patients in each arm. So, just like we've seen from all of the previous studies, blood loss is significantly different, around 250 to 260 cc's less in robotic cystectomy. Operative time, same as before, increased by around 70 minutes in robotic cystectomy. Length of stay, no difference. Complications, no difference. This is all complications. Major complications, no difference. Surgical margin, no difference. And I think we start seeing a pattern that really there's not much of a difference between the 2 groups. And again, lymph node yield, no difference. So overall, favoring robotic cystectomy, we have decreased blood loss, and favoring open cystectomy, we have decreased time. All the other outcomes show no difference in this systematic review. And there was one other review put out this year as well that showed the same conclusions.
So a question for people who wonder about methodology in clinical trials is, does a systematic review and meta-analysis of a series of underpowered RCTs improve the validity of the data?
Probably not significantly. I think it would be much better to have a high quality 1B RCT rather than multiple small ones. It may improve it slightly, but I think the findings are the same throughout these studies.
I'm wondering what the teachings are there from a Cochrane or a meta-analysis point of view. Are you supposed to include most underpowered trials? I'm just wondering what the teachings are there.
We're supposed to examine the underlying populations first to determine can they be combined. And that's a huge problem because going backwards in the text you can't often determine that. And so what you're supposed to do is actually contact the authors and try to get additional information to determine if they can be combined on a most basic level. So that's an initial problem.
So there are ways to assess for heterogeneity of data and to rate studies based on their heterogeneity. You can determine if the results can be combined. But I think Lynn's exactly right. Most often it comes down to getting the original data if you're going to take something from underpowered to powered.
If they did a meta-analysis at the time of Christopher Columbus, the conclusion would have been that the world was flat. It's still garbage in, garbage out for you, unless you get the original data. Adjust for that.
Okay. So from that, recommendations, CUA from 2016 basically said lap and robotic radical cystectomy are other options, and that there's no difference in the data to be able to recommend one over the other. The EUA, their guidelines came from 2014, and so are slightly dated. They include retrospective data. They show longer operative time, major cost, but shorter length of stay, which is questionable based on the randomized controlled trials we saw. They also say that there's decreased 90-day complication rates, which from the RCTs, again, doesn't seem to be the case. But I think what's important here is that surgeon experience and volume at a center matter more than the approach, and so they go on to recommend that you should select experienced centers, surgeons that are good, rather than specific techniques at this point.
How did they even come to that conclusion? There was no mention of any surgeon experience in any of this stuff.
I think from the retrospective data. So
There's a lot of evidence that surgeon volume,
high volume, yeah.
is beneficial in cystectomy. So I think we're just
Sure, but we didn't
applying
see
that
it here.
No, that's not in any of the randomized controlled trials. Though all of the RCTs, the surgeons were at high volume centers, but it doesn't really show us much. Most of the surgeons performing the surgeries in the RCTs had performed more open surgeries as compared to those doing the robotic cystectomies. So, what's in the future? The study from 2013, the pilot study, was just a precursor to the RAZOR trial. So this is a study, 320 patients randomized 1-to-1 to open versus robotic cystectomy. It's a non-inferiority trial looking to show no or less than 15% difference in 2-year progression-free survival. It's being done out of multiple centers, 15 to be exact, T1 to T4 disease, N0 or N1, M0, bladder cancer, or refractory CIS. Exclusion criteria similar to previous, and then secondary outcomes divided into pathologic, perioperative, and the morbidity. So similar to what we were seeing previously.
So this is actually anti-cancer endpoint?
Yes. Yeah, rather than lymph node yield or it's a 2-year survival.
What's the sample size?
320 total. When they published this paper at the end of 2013, they had 306 of 320 patients recruited already. I think they are now finished with all their recruitment, and Dr. Black was saying expected publication should be sometime this coming year or possibly in 2018.
Who presented this? You have to present
results, not the it might be asking.
So this may give us a little more information, level 1B evidence for options. Now, for this, all diversions again are being done in an open fashion, so no intracorporeal urinary diversions. And to qualify for this, the surgeon had to do at least 10 open or robotic cystectomies in the past year.
Usually when you, again, clinical trial design question, primary endpoints tend to be at least, by the time you get to randomized trials, somewhat hypothesis already shaped by data that would suggest that the primary endpoint should be affected by the treatment intervention. Why would somebody think that cancer outcomes would be improved by one technique over the other?
I think they're just trying to show non-inferiority. So,
But then
What's your advantage?
what's the advantage? I mean, you're going to all this effort.
it's a
The
lot.
primary endpoint is what dictates the trial outcome, not your secondary endpoints, which are being collected here for. I'm just struggling with why they would.
What primary endpoint would you prefer?
Probably perioperative morbidity, which is what the surgical technique is designed to alter. It's not there to say that it's going to be a better anti-cancer. Nobody's promoting it as a better anti-cancer.
And I don't think the authors are trying to promote that either. I think that they're trying to give good level 1 data that it's not worse. Because I think there have been questions in the past about that.
None of that came up in any other trials that robot would interfere with.
No.
Anti-cancer outcome.
Yeah, it's interesting, because things that have come up since they've started this trial is this idea that you get atypical recurrences robotically with ADR with no apparent need. I don't know if you have any slides.
Yeah, I've got a couple.
And so you could, but they weren't thinking, I don't think they're necessarily thinking of starting the trial.
No, because that was published after this was started. So in terms of long-term survival, there was just one retrospective, or one good large retrospective group, 702 patients. The International Robotic Cystectomy Consortium, so 11 centers from 6 countries. This is a prospective database that is being reviewed retrospectively, and their pathologic outcomes for robotic cystectomy, 62% was organ-confined disease, positive surgical margins in 8%, and positive lymph nodes in 21%, with a median lymph node yield of 16. What they found, non-organ confined disease and positive surgical margins were associated with poor outcomes, which I think can be expected based on history with open surgery, and their 5-year survival rates you can see there. Cancer-specific survival 75%, so similar to what's been seen in prior open cystectomy groups. Then there's 2 more things that we're going to cover. The first is intracorporeal urinary diversion. So is there any difference between doing the entire surgery robotically versus opening the patient up for the urinary diversion? From all the data so far, it doesn't seem like there's much of a difference between robotic versus open surgery, but there has been some retrospective data now that shows some improvement with intracorporeal diversion versus extracorporeal. So this looked at 935 cystectomies performed over about a 10-year span. 167 were done in an intracorporeal fashion, 768 extracorporeal. No difference in OR time between the 2 groups. It was thought, and in other studies it's shown, that the intracorporeal diversion does take longer. Post-operative complications were 32% lower in, that's a relative reduction, not absolute. So decrease in complications in intracorporeal versus extracorporeal. 90-day readmission rate was lower, and the GI complications were significantly lower in the intracorporeal group. Now again, this is a non-standardized retrospective study, but it does give some insight that there may be benefits. So another study from TAN looked at 184 patients, about half and half, open versus robotic. Again, this is prospectively maintained, but a retrospective analysis, not randomized. And this study had significant bias again towards lower stage in robotic cystectomy, as well as a decline in neoadjuvant chemotherapy in open cystectomy. They showed no difference in any of the survival endpoints that they looked at, but again, retrospective data. No comment in this paper on complication rates or other perioperative data.
Of course, doing a diversion intracorporeally or extracorporeally is going to have a big impact on cancers. That makes no sense.
Doesn't make sense at all. No, because really what you're looking at for the intracorporeal versus extracorporeal is your perioperative outcomes. That's what actually matters. And then finally, what Dr. Black touched on earlier, there was a question brought up by Nguyen out of Cornell. It was published in European Urology in 2015, and they looked at a retrospective review of 380 consecutive patients, including 263 done robotically. They were done using the extracorporeal approach. They found similar number of recurrences overall, but the concern that was brought up was that there were distinct patterns of distant recurrence. So for patients who had distant recurrence, there was an increase in the number of patients with peritoneal carcinomatosis as well as extrapelvic lymph nodes. And the question they raised is, does pneumoperitoneum cause increased seeding of cancer cells? So any spillage or any cancer cells that are lying around in the pelvis, does the pneumoperitoneum push those around and cause them to seed at a higher rate than with open surgery? Now, there was a response from Dr. Black. There was no real statistical analysis on this. They just presented some numbers, and their data, when you re-looked at it with a statistical analysis, didn't really show much difference, if any, that robotic surgery compared to open surgery would have an increase.
Colin, in that review,
Yeah.
if you were implying before that patients who underwent robot were more selected towards, this is all retrospective, so not prospectively randomized, patients who are opted down to go into robot are the better selected.
Lower stage.
Lower stage.
Yeah.
And yet recurrence rates were the same.
Yeah, so conclusions could be drawn to an extent from that as well. So if you have lower stage disease but same recurrence rates, then you would expect to have lower recurrence rates with lower stage disease.
Multivariate analysis and surgical approach would stood out. Did they do something like that?
So they did an analysis on overall recurrence, but I'm not sure. I'd have to look back at the data to see if they included the lower stage in that multivariate analysis. A couple years later, or actually a year later, they published a second paper with the goal of trying to assess for predictors for this atypical recurrence. What they found, predictors of recurrence, were the same as previously known for open surgery, tumor stage, LVI, and positive margins, which isn't surprising. What they concluded was that atypical recurrence, primarily peritoneal carcinomatosis and extrapelvic lymph nodes, is influenced by tumor biology and not by surgical approach. This is the same group publishing data saying that what they originally found is likely not clinically significant. There was another study, 717 patients undergoing robotic cystectomy by Colin, published in European Urology about a month and a half ago, and this was out of Europe. They showed no increase in atypical recurrences. So whether or not there are atypical recurrences would probably require a very highly powered, large number randomized trial to take a look at.
The razor trial.
You think it, with 320?
300 patients.
Yeah.
Randomized open robotic to see if they're
So, in conclusion, robotic cystectomy is associated with lower blood loss but increased OR time. Compared to open, there's no difference with respect to overall or major complications, lymph node yield, length of stay, or positive surgical margins. Despite any level 1 or solid level 1 evidence, utilization of robotic cystectomy is increasing. Hopefully we will get some good information out of the RAZOR trial that should come out in the next year to year and a half. And in terms of the intracorporeal urinary diversion and any benefits over extracorporeal diversion, they're going to need to do a prospective randomized trial to show any significant improvements. Thank you.